Hello, and welcome to MedNews Week, the rising leader in global medical education. You're watching Medical Spotlight, where we highlight the inspiring stories and pioneering research innovation of medicine's rising stars and global leaders.
And welcome to Medical Spotlight. I'm Gayatri Menon.
And I am Madhuri Balasubramanian.
Today we have with us Dr. Adam Faye. Dr. Faye is an assistant professor of medicine and population health in the division of gastroenterology at New York University Grossman School of Medicine. He completed his undergraduate degree in biochemistry at Harvard University and medical school degree at Weill Cornell Medical College. He completed his internal medicine training, chief year, and gastroenterology fellowship training at Columbia University Medical Center. During his gastroenterology fellowship, Dr. Faye also completed a master's degree in biostatistics at Columbia Mailman School of Public Health and pursued an additional year of advanced inflammatory bowel disease training at the Icahn School of Medicine at Mount Sinai.
Dr. Faye's research interest is focused on the intersection of geriatrics and gastroenterology. His specific focus area centers around the understanding of how biological measures such as frailty and sarcopenia can be used to improve both risk stratification tools as well as clinical outcomes among older adults with inflammatory bowel disease. He has received funding from the NIH and the NIA, the American College of Gastroenterology, and the Crohn's and Colitis Foundation to advance this work as well. Dr. Faye is also the co-chair of the NIA-funded ClinStar Frailty and the Inflammation Group's Geriatrics Section Editor for the current treatment options in gastroenterology, a member in both the ACG Educational Affairs and Research Committee, a member of the REACH IBD Rising Educators, Academics, and Clinicians, helping IBD, a member of the American Gastroenterological Association Young Delegates Program, and was also selected for the 2022 Advances in IBD Ambassador Program, the 2022 ACG Early Career Leaders Program, as well as the 2023 NIA Butler Williams Scholar Program. He has definitely published an extensive research in this area and has been invited to speak both nationally and internationally on his research. He's also a passionate mentor, serving as a leader, educator, and we're honestly delighted to have him here today.
Thank you so much for having me. That was way too kind. So thank you again. It's really a delight to be here and to meet you both and to be part of this amazing platform. So thank you.
Thank you so much, Dr. Faye, for having the time to be here with us today. So my question is, behind every person in a white coat is a story and mission for why they pursued this journey and career. Could you tell us about yours?
Absolutely. And so it started, I think, much like many of my peers, including probably both of you, but always passionate about helping others, really since an early onset. And when I was in actually middle school, my father actually became very ill. He had Guillain-Barré syndrome. So we actually spent months within a hospital, specifically within the intensive care unit. That obviously took a large toll on my family. But on the alternative side, it was really amazing to see how the entire healthcare community, the entire staff at the hospital was really not just focused on my father and combating his disease, but really taking care of the entire family. So they were making sure my mother, my brother, and myself were all cared for and really focusing on this biopsychosocial nature of care. So again, not just focused on the disease itself, but really how it impacts the person and their family and extends beyond that. And that really stood out to me at that time, and that cemented my desire to pursue medicine. So this was early on. And then I actually afterwards joined the local ambulance company in my community. So I started on the junior ambulance squad as a lieutenant and then captain. At that time, I also obtained my EMT, my emergency medical technician license. And as I was going out for these calls, this is when it started to get into this idea of geriatrics. I started to notice a lot of calls that we were being called for were older individuals in the community who were having falls in the bathtub. And while I was happy to be able to go out in the ambulance and help provide care for them, I really wanted to focus, well, how can we prevent these falls in the first place? And so that led to a program that we developed called MATS, which was Make a Tub Safe. and I ended up calling a number of different companies all over the US and actually received donations of over 1,000 bath mats to our local ambulance company. And we went out to multiple different senior centers around the community, and we handed out these bath mats and really hoped to try to prevent these falls in the older adult patient population. And that really sparked my passion for geriatrics. And so after college and undergrad, I actually spent an additional year doing basic science research in mantle cell lymphoma, which predominantly affects older adults as well. And that was at Weill Cornell Medical College. This interest really extended into medical school. So I did a geriatric sub-internship. During my residency training, I did additional geriatrics rotation. And similarly, I really loved being able to spend time with the patients and their families. And again, not really just addressing what the ongoing disease process, but trying to understand that biopsychosocial component. So really focusing on what matters most to our patients and to our older adults. How can we best advocate for these individuals? And during this time as well, I became very interested in GI, the underlying pathophysiology of disease. I was interested in the procedures. I had family members with inflammatory bowel disease. And really, this was a way I could start bridging both of these passions, so geriatrics and the world of gastroenterology. And so during residency, my chief year in GI fellowship, I really became passionate about trying to understand how chronic gastrointestinal illnesses impact patients and trying to really address knowledge gaps in the field. And at that time, I realized I had some background statistical knowledge, but I had some of my own knowledge gaps. So that's when I applied for a master's program. And actually during my GI fellowship, I did night courses and some other courses and completed a master's in patient-oriented research at the Columbia Mailman School of Public Health. And then after that, I did an additional year of subspecialty training at the Icahn School of Medicine at Mount Sinai in inflammatory bowel disease, and was really a wonderful year learning both clinical and research within IBD. And then since then, I've been an assistant professor of medicine and population health here at NYU. And as you mentioned, my research has really been focused on bridging the field of geriatrics and gastroenterology, and particularly inflammatory bowel disease. And I've been fortunate enough to have funding from the Crohn's and Colitis Foundation, the American College of Gastroenterology, and the National Institute of Aging to help support this work. And I'm delighted again to be here and to speak to you about some of that. And again, just want to thank you for the invitation.
Thank you so much, Doctor. That was really inspiring to hear. So my question is about your strong passion for mentorship. How does it manifest in your present role? And could you describe the ways in which you're currently applying mentorship to guide and support the development of your junior colleagues?
Absolutely. You probably can't see it, but I have a whiteboard behind me, and I've got all those projects. And I think about every one, but about one or two of those are with mentees. So work with a number of trainees from all levels, even including high school students and college students to medical students at NYU and beyond, as well as residents and fellows, and have published extensively with them. I also have I've been fortunate enough to work with a resident who is now at Duke University, Kay Lee, who actually has an ACG Resident Award that I'm her primary mentor on. And I'm working with another wonderful medical student here at NYU, Catherine Tang, who's putting in an ACG Medical Student Award. So it's really been amazing to be able to work with individuals who are so passionate about many of the same things, really improving patient care and patient outcomes, and how we can best support our patients and understand and really focus on some of the knowledge gaps in this area. And so it's been amazing to be able to mentor so many of the young future. And I'll say the future is incredibly bright. And I'm still only a couple of years out, so I'm not 20, 30 years from now, but it's really been incredible to be able to work with so many amazing mentees. And I'm just floored by how passionate, how driven, and how bright they are.
So it sounds like you're an incredible mentor just listening to you. So what do you think makes a good mentor, and who is that for you?
Absolutely. So I've had so many different mentors. So I will say there's no one good mentor. The best piece of advice I ever received was have multiple mentors, right? Each person will serve a different role, and they'll have different input, and you can learn from all these individuals. Everyone I've really had touch points with have really kind of made me who I am today and informed me. from my mentorship during medical school at Cornell and during my time at Columbia. Ben Lebel and Chin He were amazing mentors, and Dan Friedberg. And then during my IBD year, John Fred Colbell and Bruce Sands. And then at NYU, there's been amazing. The geriatrics chief here, Josh Chodos, John Dotson, Asma Shaukut, who I think was on your show before. So have a multitude of mentors, draw from their level of expertise. And I think what makes a good mentor is someone who's invested, and someone who really can give you what you need. So if you need someone on the ground level, helping you think through research studies, giving you that framework, someone who has a little bit of statistical background, as a mentee, you can be explicit with, these are my areas that I have in strengths, and maybe these are some areas that I don't really particularly know. Maybe it's statistical analysis. And then that mentor can help shape, I can help you with this aspect and really focus on it. I'm going to connect you with, X, Y, and Z other faculty who can really help fill in these gaps that I may have. And I think that's what makes a really outstanding mentorship team. And yeah, have multiple mentors, and I think have people who are invested in you, invested in the project and your success. And I think as mentors, we all want to see our mentees succeed and really give them the basically the tools to help them flourish. And I've just seen amazing things.
Thank you, Dr. Faye. That sounds really great. That was really incredible advice. So, human beings all deal with setbacks, right? So would you mind reflecting on a challenging time in the past for you that you overcame, and how did it either make or break you, would you say?
Yeah, there's a ton of challenging times. I think, just since it's on the top of my head, but that time when my father was ill during middle school to high school transition was extremely difficult. My brother was in college at the time. The hospital was over an hour away from my house because he needed specialized care. So my mom wasn't really present. So for months at a time, I was essentially home, navigating school. And it really was incredibly difficult. And to get up each day and even focus on education and putting everything else out of my mind. It really wasn't possible. I was constantly just thinking about being at the hospital. But again, having had that experience, really able to understand where our patients come from. I've been a patient myself, multiple things, and understand where our patients' families come from. And I think that gives us also a different understanding and a different way that we can empathize with what our patients are going through. And it really helps kind of shape who you become as a physician as well. And so while that was a extremely challenging time, being able to see the way the healthcare system really, again, just focused on caring for the entire family and not just focused on the disease, and then understanding all of that, now being able to kind of give back to that element now that I'm on the other side sometimes has been really rewarding. But that was, again, it's the closest thing on my brain right now, but that was an incredibly challenging time that, there were some days where I just didn't want to go to school or, just didn't want to get up and go do the things that I needed to do. Because it was very, very challenging and very, very sad.
Thank you so much, Doctor, for sharing that, personal story. We've already gotten a wealth of knowledge from you already. So for our junior trainees and our audience, what is a key piece of advice that you would like to impart to them?
For sure. So reach out. I can just speak to myself and to all my colleagues that I haven't experienced anyone who doesn't, but we're always happy to receive emails from mentees. So don't be afraid or scared. Reach out all the time. Let us know how we can help. We are here to help. And we realize that we have had, and I still have, a ton of people who are helping me along the way. And we want to give back and we want to help support the young generation of trainees as well. So please reach out to us. Let us know how we can be of help, even if it's just a 30-minute meeting that we can connect you with other people who might be able to help in other ways. We are here. We want to help. Keep us kind of in the loop, access us as best as we can. And yeah, just really, really, I think harness that. It's, again, I wouldn't be here without the support of so many of the people, including a number that I hadn't mentioned. And I think just involving people from an early on that can help shape who you are, both clinically, research-wise, academically, can help with work-life balance, all these things. If you have this question or interest, or someone has thought about it or is thinking about it or has worked on this area, so reach out and we can help kind of put you in touch with those folks, or kind of help in any way we can support.
Thank you so much, Dr. Faye. Thank you so much for that, wealth of knowledge. And it was really great hearing from you and your story as well. It's so inspiring. Thank you so much.
Of course.
And, honestly, Dr. Faye, I think that was a really enlightening sharing session about your unique background, your challenges and success. And I think from just knowing about you, not just our trainees, but your mentees and your mentors will definitely learn more about you as well. So thank you for that.
Of course, thanks for having me and letting me speak about all those things.
And to go a little bit more about what you're working on and the research that you're very passionate about, you had published a paper this year looking into the interplay between IBD and antibiotics and how a lot of factors and the increasing incidence about it. Could you tell us a little bit more about that and share a little bit more about this research?
Yeah, absolutely. So let me actually pull up while we're chatting, if you don't mind. I have one slide on it. So I can just show you that as we're doing it. Let's see if this works. I will tell me if
you can see it.
the screen. Okay, let me go to this right here. So I think this is the antibiotic study that, when we talk about inflammatory bowel disease, it really has a bimodal peak of incidence. So I think traditionally we've thought about inflammatory bowel disease as a disease of younger individuals, but we realize that there's a second peak around 60 years old. So there's a whole population of older adults who are developing inflammatory bowel disease. In addition, there's an entire population of adults who are younger when they develop inflammatory bowel disease, but are now aging. So really, the number of older adults with inflammatory bowel disease is really rapidly increasing. We think about 20 to 30% of all individuals with inflammatory bowel disease are over 60. These are over 60. Okay, so when we speak about the older onset inflammatory bowel disease, IBD in general, while we don't understand exactly what leads to its development, it seems to be some complex interplay of the environment and genetics and a host of other factors. But what's interesting when you look at older onset individuals with inflammatory bowel disease, they have much lower likelihood to have a family history. So we think perhaps that the genetic component is smaller and maybe the environmental component is larger. And this has been looked at antibiotics in the development of inflammatory bowel disease, but a large proportion of the studies had looked at early life exposures or earlier in life. And our question was, if environmental exposures are really leading to the risk of developing inflammatory bowel disease later in life, perhaps antibiotics may be one of these environmental factors that are driving it. So in conjunction with some of my mentors at Mount Sinai and also with the Denmark National Predict Center, which is an amazingly powerful cohort of individuals and center that's led by Dr. Tina Jess in Denmark. And what we did was we looked at a cohort over 10 years old from 2000 to 2018. So you're looking at 6 million individuals who have minimal loss to follow-up. And so we have 87 million person years of follow-up. And essentially, we can follow these individuals over time and see who develops inflammatory bowel disease. And we can ask the question, do antibiotics along the way increase the incident rate ratio, so the development of inflammatory bowel disease? And we specifically looked at the number of courses, the timing of the exposure, antibiotic use, and specific classes. And again, we looked at the incident rate ratios and we mapped antibiotic use from 1 to 5 years. And the reason we kind of included this 1 year of lag time. So if you got an antibiotic, we essentially made it so that you were agnostic to that antibiotic until 1 year later, because of this idea of reverse causality. So you can imagine someone shows up to a clinic, has gastrointestinal symptoms. We're not exactly sure what's going on. You get an antibiotic, and then 2 weeks or a month later, we realize, oh, it's inflammatory bowel disease. You might see this association and think, oh, the antibiotic caused it. But in actuality, the antibiotic was really being used to treat some of the symptoms. So by introducing that 1 year of time between those two events, we can really wash out a lot of that. And when you look at the risk, so this is the time in the 1 to 2 years before. That's when the antibiotic use was associated with the highest risk of developing inflammatory bowel disease. But you can see, even if the antibiotic was 4 to 5 years prior, you can still see that there's an increased risk of developing inflammatory bowel disease. And you can see here, these are the ages. So if you look at the younger cohort, 10 to 40, yes, there's certainly a risk. But if you look at the older cohorts, 40 to 60 and 60 plus, you can see that both of these curves are significantly higher, so that the incident rate ratios are more significant for our older adults. So antibiotics seems to be perhaps playing a larger role in the development, or is at least associated with the development of IBD at a higher rate in the older adults. When you look at the number of courses, you can see this dose-response relationship. So the more courses of antibiotics, the higher the risk of developing IBD. And interestingly, if you look at the classes, you can see many of the classes of antibiotics are associated with the development of IBD. But fluoroquinolones and nitroimidazoles like metronidazole, which we often use to target gastrointestinal infections and pathogens, so they really target the gastrointestinal microbiome, those are associated with the highest risk. And interestingly, some of the more narrow antibiotics are associated with a lower, and nitrofurantoin, which really doesn't impact the intestinal microbiome much at all. It's really absorbed by the small intestine, doesn't seem to increase the risk of inflammatory bowel disease at all. So this really suggested to us that perhaps antibiotics are doing something to the intestinal microbiome that's perhaps increasing this, the relative risk of developing IBD. And again, within the older adult population, we see this risk to be a bit higher than the younger adult population. So that was one of the studies that we had done.
And honestly, I think that's very interesting, because something that you had mentioned, and I read your paper on that as well. Since you spoke about the 1 year lag time and as well, I remember you had mentioning that how the course and the number of the antibiotics is honestly a time varying variable, with only a certain risk time for each of them following exposure. And I think that's something that's very crucial for all of us to know, as not just students, but also future professions, because we know that a sensitivity is going to be there and we need to further limit this potential. So thank you for sharing about that. What would you say was a limitation or a challenge you encountered during the study with especially different organizations involved, and how were they addressed?
Yeah, so limitations, I guess, just in terms of limitations of database studies, so associational, not causational. So unfortunately, can't go into the microbiome and really assess from just a population ecological study what's going on. And is there, we think that there's biological plausibility. We see this dose relationship. We see the different antibiotic classes. It all kind of speaks to this biological plausibility, but we can't say causation. So that's certainly one. Another we talked about a little bit, we did include the 1 year of lag time. The possibility of reverse causality and other confounders are always there. We do see this association persist even 5 years out, so that, we don't think that someone would have an antibiotic 5 years prior for undiagnosed inflammatory bowel disease and then go 5 years without a diagnosis. So again, it's a limitation, but we tend to think that that's a more minor limitation. And I think those were essentially some of the biggest limitations of the study. And I think the next kind of steps for that will be trying to understand a little bit more of the basics science aspect of this. I will add one other thing. So while we look at antibiotics, these are prescriptions. So did individuals take the antibiotics? We don't know. They were just prescribed the antibiotics. And on a caveat to that too is infections can drive up the inflammatory response. Inflammation, which we just published a paper looking at atherosclerotic related inflammation in the development of IBD, but inflammation itself may be a trigger for the development of IBD. So it's very hard based on this study to tease out antibiotics and infection. Perhaps it's the infection that's driving some of that risk and less so the antibiotic. Though again, we don't think that that's quite the case. There's been some prior data showing antibiotics plus infection, the risk is higher than infection alone. And again, when we see the way that the antibiotics are playing out, so some antibiotics who don't infect the intestinal microbiome, not leading to the development of inflammatory bowel disease, the narrow spectrum some, and the more broad spectrum with a larger degree, that suggests that there's something inherent to the antibiotic and less so inherent to those specific infections. But again, it's difficult to tease out. So we don't know why those individuals were getting those antibiotics and can't tease out what if you had that infection and you didn't get an antibiotic.
No, that was honestly really interesting to know that these challenges itself are the same questions can be further worked on, and that'll kind of change how the whole results affect the medical practice itself and how we can further develop on that. And since you spoke a little bit about some other things that you're working on, could you tell us a little bit more of some other research you're presently working on and you'd like to share about?
Yeah, absolutely. I can I'll just spend a couple minutes. I can show you. So this was can you see my slide again?
Yep.
Okay.
Yeah.
So this was a study that we recently did. So similar question. And so we see within inflammatory bowel disease that particularly in the time soon after you're diagnosed with inflammatory bowel disease, there portends or there seems to be a higher risk of atherosclerosis or cardiovascular related events. And then it seems to plateau later on. And so this idea really sparked this thought that perhaps this atherosclerosis or cardiovascular disease may actually not be occurring right after the development of IBD, but perhaps it's actually present for a time period before that, whether it's diagnosed or undiagnosed. And so that led to a study, again, really focusing, asking the question in all adults, but particularly older adults with inflammatory bowel disease, who we think environmental factors may be playing a role. Do we see evidence that atherosclerosis-related inflammation may be a driver for the development of inflammatory bowel disease? And so this was a study we did in conjunction with Jonas Lugvidsson and some others over at the Karolinska Institute, and it used the Swedish national database, and we looked from 2002 to 2001, and we looked at individuals who had IBD, individuals who didn't have IBD, and we looked back to see if they've had a prior diagnosis of either a myocardial infarction, so a heart attack, atherosclerosis, so plaques within the arteries, or a thromboembolic stroke. And if you just look here, are you able to see my cursor or? Yes.
Yeah.
Okay, perfect. So if you look here, if you look at the overall risk, you can see with an IBD, 4.2% had a prior atherosclerotic related condition compared to only 3.4% in the controls. And again, this may underestimate it because there may be a large proportion of individuals who have atherosclerosis that just haven't been diagnosed yet. But you can see that there is an elevated adjusted odds ratio in our conditional logistic regression. So again, suggesting that individuals with inflammatory bowel disease may be at a higher likelihood to have atherosclerosis. When you look at the subtypes, atherosclerosis itself had the highest risk. When you look at the timing, atherosclerosis within the 6 to 12 months was associated with the highest risk as opposed to having it for years before. And we saw a bit of a dose-response relationship where having 2 or 3 of these atherosclerosis diagnostic conditions increase the risk a bit more than just one. And again, if you look at the older adults, so 40 to 60 and greater than 60, you can see that the odds ratio are a bit higher than those who are 18 to 40. So again, perhaps suggesting that older adults having atherosclerotic related inflammation may be associated with the development of inflammatory bowel disease, and particular within the older adult patient population. So that's one of the studies we've been working on. I will fast forward through some of this stuff, but basically I just wanted to highlight that a lot of our older adults with inflammatory bowel disease, although there's really no significant difference in the severity of older onset IBD versus adult onset IBD, you can see that these are pretty similar across the board. And disease does not seem to burn out over time, meaning that someone who has disease for 20 or 30 years, we don't think that their disease is done. With Crohn's disease, it seems like that disease is still there, but somehow we seem to be treating our older adults with inflammatory bowel disease a bit differently. So you can see using our biologics or thiopurines, those who have older onset inflammatory bowel disease are much less likely to receive these drugs. And we had just done a study looking at over 22,000 samples. And even among those older adults who are receiving this drug, they're also more likely to receive a lower dose of the drug. So again, very concerned about safety. But I think one of the things to really highlight is that when you're focusing on inflammation and the role or the attributable risk of our medications, rather than just comparing older to younger adults, if you look at the older adult population and you say, those with moderate to severe ongoing inflammation, so those who have that colonoscopy that I quickly showed with all those ulcers, if we leave them alone and just leave them on placebo, or if we give them this drug that we're worried about side effects, what happens? Well, in our randomized controlled trials, you can see that if you give them the drug, if you lower the degree of inflammation, you actually have a lower rate of serious adverse events compared to the dark blue versus light blue, a lower rate of hospitalization, a lower rate of severe infection. So all really highlighting this idea that if we can control the inflammation, particularly with our older adults with IBD, we can actually improve outcomes. And so just very briefly, this really has sparked my research interest, but trying to move the field away from using this idea of chronological age and more towards biology or frailty, which I have down here. And so just as an example, I like to show this picture. It's two individuals, same age. One was a previous Speaker of the House very recently, and another is using, needs a two-person assist essentially to move across the clinic floor. So you can see that chronologically may have the same age, but biologically may be very different. And so this has come to a lot of the research that we've been doing, myself and Bharti Kochar up at MGH, looking at how frailty can actually be used to risk stratify and improve clinical outcomes. And you can see that frail individuals have a much higher likelihood for infections after you're treating them with immunosuppression. We did a study looking at readmission mortality and readmission in general, and frailty independent of age and a number of other comorbidities was associated with these outcomes, again, suggesting that frailty may be important. I'll skip through this. Again, with mortality. And this was a nice study really showing that in patients, all ages who have ongoing inflammation, 27% of them who had ongoing inflammation were frail within the year. So this idea of leaving inflammation untreated or suboptimally treated may actually lead to the development of frailty over time, as opposed to those who had response to therapy. And so we just published this basically review of managing the older adult with inflammatory bowel disease, but it's adapted from a prior work from Linda Fried and others looking at the development of frailty over time. And with ongoing inflammation, you have these stressors that can kind of drive the development of frailty. But if you actually intervene early, control inflammation, you can actually mitigate and lessen the degree of frailty over time, as opposed to letting the individuals continue to have ongoing inflammation. And then so that has sparked some of our work also looking at some surgical outcomes. And I'll finish up with the last 2-3 slides quickly here. But this was trying to understand why older adults with inflammatory bowel disease have a significantly higher risk of adverse outcomes as compared to younger adults. So you're talking about maybe 1/3, if not higher, have a major 30-day adverse outcome. And when you look, this was a study that we recently did at older adults versus younger adults. You can see based on the age that the odds ratios for the factors are actually pretty similar. So older adults and younger adults, it seems like functional status, emergency surgery, preoperative sepsis, malnutrition seem to be driving the outcomes in both groups. So why the difference? Well, if you look, older adults are much more likely to have a dependent functional status, to need emergency surgery, to develop sepsis, and to have malnutrition. And I think because of this idea of using chronological age, we tend not to want to operate on chronologically older adults. So by not understanding the biology, we just tend to defer surgery in older adults. And with ongoing inflammation, these patients are at risk to develop malnutrition. They're at risk to develop preoperative sepsis, to come in now needing an emergency surgery. The problem is when they come in with those things and we do operate, they have an adverse outcome. And what it tells us is perhaps we shouldn't operate on chronologically older adults, but what it really should be telling us is perhaps have we operated earlier when they were more fit and not allowed inflammation over time for them to develop more dependent functional status or a higher degree of malnutrition, or now they have sepsis or needing emergency surgery, we actually could have intervened earlier and had a better outcome. And this just quickly was an older study showing the same thing. They looked at elective surgery versus medications and mortality over 5 years in ulcerative colitis. And the biggest group that had the benefit was age over 50. And so we had done a recent study that was just highlighted as well on the cover of Gastroenterology, looking at limited Crohn's disease, medical therapy versus surgery. And surgery had a lower risk of hospitalization, steroids, need for follow-up surgery. And the group that had the greatest benefit, again, were the older adults. So I'll pause there can go through the take-home points, but I'll just leave them up there for a second. Happy to answer any questions or anything else. Sorry if that went a little long.
No, honestly, that actually answered one of the questions I was going to ask you about, which is more related to the early onset and late onset, which you had actually covered. So that was great. Another question that I had, and this is first of all a very interesting PPT. I'm going to read more about this. With IBD being such a particular disease, and with geriatric population having a decline in immune function influence, how does this influence the course and the treatment plans? And are there implications in the approach of the treatment itself?
Yeah, that's a great question. So we need more data. We're working on it. This idea of immunosenescence, so that the immune system over time ages, and perhaps does the disease burn out, or do we need different treatments and so forth? So we don't have great data. I flashed the survey very quickly. It's an interesting survey. It's, I think, from 1980s or so. So it's quite old, but at the same time, it's also before we had many treatments. So it really gives you a natural history of the disease. And it surveyed patients who had Crohn's disease at 3 years from their diagnosis. So they've had it for 3 years, or they've had it for 25 years. And they basically looked at what are the percentage that had a flare within the last month, and what are the percentage still needing some medical management. And the percentages were pretty similar. So it suggests that even though there is this immunosenescence that occurs with inflammatory bowel disease, we don't see how it plays out in time, meaning we don't think that the disease burns out. Interestingly, when I was talking a little bit, I didn't focus on it, but the study we did with 22,000 samples, where we looked at the dosing of some of the biologics. With immunosenescence, you would think some of these are large molecules, they're half murine, so they're half mouse, so you can make antibodies to them. And you might think over time, older adults may be at a lower risk to develop antibodies. Maybe that's why, we're trying to use a lower dose or whatnot, even though no data has shown higher dose worse outcomes. But what we actually found was that older adults, so 60s, 70s, 80s, actually had a higher risk to develop antibodies, even independent of the dosing. So meaning when we adjust for the different level of dosing, older adults still seem to be at a higher level for antibodies. So what we can at least say is they're not at a lower risk for antibodies. So that idea of immunosenescence, burning out the disease, or not leading to antibodies related to our medical management doesn't seem to play out. How does that translate? I think it means that we really need to be controlling the inflammation within our older adults using the appropriate modality. So we need to be using our advanced therapies if there's moderate to severe disease. And the biggest key is, of course, we're always concerned about safety and thinking about our medical therapies, but also in older adults who has ongoing significant inflammation, first of all, quality of life, but also leading that inflammation ongoing over time can actually drive them perhaps from a fit to a frail state. So you need to think about, well, what are the risks of under-treatment of that patient over time? But this is what we're working on, and I hope maybe I'll be invited back in due time and can give you some updated results on this.
We'll definitely love to have you back for one of our sessions where you're able to talk extensively about the research as well. And to add on to what I was just saying right now, with you being so passionate about advocating for this, what do you think are the gaps that exist in the current understanding of the IBD epidemiology in not just the geriatric population, but overall? And where do you think future research should be more focused? And, would it be better to have a specific data contribute to the overall understanding?
Yeah, there's a lot of knowledge gaps, which we're all trying to work on as a consortium, as opposed to siloed approach. So there's a lot of overlap with frailty and sarcopenia and nutrition. There's a lot of interest in how diet can also help modulate inflammatory bowel disease. And it's interesting, I'll break it down into two really different topics. There's the prediction and prevention, which a lot of my Denmark colleagues and Swedish colleagues, which I've mentioned, work on. And that's really trying to understand what is the basic science, the epidemiology of disease onset, what kind of plays into that. And then there's once inflammatory bowel disease is present, how can we mitigate the risk of adverse outcomes long-term and improve the quality of life of our patients. And so that's a lot of the other focus. So that focuses on nutrition on one aspect. We're focusing on frailty and sarcopenia as another aspect. And there's really a lot of work being done. There's being work done right now looking at combination of different medical therapies. So we've traditionally been using one at a time, kind of sequentially to see what works and what doesn't, trying to understand what are the inflammatory milieu that drives disease in one person versus another. Maybe we can figure out which is the better medication. Perhaps combination of 2 or 3 different types of medications may be better in some cases. Does earlier surgery in some cases work better? There's a lot to be working on, and also trying to understand how we can help our patients' quality of life in addition to just outcomes is critically important. So we're doing a lot of survey work as well, interviewing patients, sending surveys out, trying to understand their clinical symptoms, how it, again, that biopsychosocial model, how it really, not just focus on the disease, but really impacts their whole life, and what we can do to help support them in all of those aspects. So there's a lot. I'm happy to say there's a ton of research going on, which is great. We need to be doing more. And yeah, it's an exciting time, and I'm hopeful that we'll just continue to have more and more answers over the next few years.
We really appreciated the opportunity to learn about you and also about the work you're doing with not just the disease, but the course, the treatment, and also the implications from the treatment as well. So we have one final question for you. With everything kind of said and done, what do you still hope to achieve further in your career, like you had mentioned? And what is something do you want to be remembered for?
That's a good one. What I want to be remembered for, I think largely that I was just passionate, patient advocate, trying to improve. It would be amazing if we can figure out how we can best improve our patients' outcomes and quality of life. So that's what I'm really striving for. My 10-year plan is really to continue this research, to push the field away from chronological age, to understand how to use frailty, to improve our risk stratification tools, to understand what drives frailty, to perhaps even design interventions to mitigate frailty, and really, particularly within our older adult population, understand also what matters most to our older adults, so that we're not just focused on treating the disease and an outcome, but really making sure that their quality of life is the best that it can be, and really that they can be able to achieve whatever they want to achieve. So I think that's kind of my 10-year plan. That's really what I hope to leave to the field, is really kind of move the needle away, and really start to introduce some of these concepts so that we can, when we approach an older adult, we have more data. We're not just looking at an age and a comorbidity list and deciding to either defer surgery or not give a treatment, but we really understand what drives those factors. We understand from a patient perspective what they're looking for and what will make them feel the best in this outcome, and then putting all those pieces together. So I think if I can leave that, and again, if I can help mentor the youth, because that's really, the future is so bright, and that's really what's going to kind of pick up the baton and continue this, I would be over the moon.
No, definitely. Thank you for that. And I think we'll also be excited to not just learn from you, but also the work you do as well.
Absolutely. Thank you so much. I'm so thankful for this opportunity. It was so lovely and wonderful to meet you both. And thank you for having me.
Thank you so much, Dr. Faye. It was such a pleasure to learn about you and your important work. Could you please share how our audience can connect with you?
Absolutely. So I'm on Twitter, or X, whatever it's called these days. I think it's at Adam Faye, MD. My email is my first last name at nyulangone.org. We have all our studies up on our NYU website, which you can access through the portal. I'm on LinkedIn, though I don't often check it, but those are probably the best ways. And I'm always happy to, again, whether it's trainees or what, feel free to always reach out. always available. And it's some of the best part of my job is being able to see the patients every day, work with trainees, work on the research. It's really, I have the best job in the world for that.